Friends, I'm Dr. NIRMAL FREDRICK. I'll be the chief instructor for this course. So this program is on managing medical emergencies in ophthalmic practice. So we have a good panel of speakers. May I request Atik, Gagan and Jayanthan to join me in the podium. Slides not moving. Okay. It's my disclaimer. I have no financial interests. I'm associated with NABH and a few other organizations in a honorary capacity. So this is the program. So I've been involved in accreditation of eye hospital for the last 15 years. So over the last 15 years, when we visit eye centers for accreditation or assessment, many of the small eye care organizations are generally not prepared for these surprises. I think last session we heard about ophthalmic emergencies. So we are tuned to manage ophthalmic emergencies. But when surprises happen in the form of a medical emergencies, which can happen because most of our patients are vulnerable patients, extremes of age, have a lot of comorbidities, we are not able to handle that emergency, so crisis erupts. So what we generally see is non-functioning crash cart or expired medicine in the emergency tray, or they don't have access to ambulance, and many of the requirements are non-existent. And the team is less resource intensive or not trained properly to manage emergencies, medical emergencies, and they tend to panic a lot in front of the patients and their families. So that actually creates a crisis, and most of us don't have anesthetists during procedures. So if we have, so which is a requirement from a patient safety angle, it will be good for the surgeon, for the team, and the practice image. So life is full of surprises. So we have to be ready and prepared to handle these surprises in our practice. And how do we go about that? So being prepared for medical emergency is not just about saving lives. It is about giving hope to those who need it the most. Because every second, the golden hour time, every second counts, every life matters, and every effort to be prepared can make a difference. So this instruction course is all about how to sensitize the eye hospitals and eye centers to be prepared on handling medical emergencies. So the first lesson is do not panic. So you have to be prepared, because saving life is part of patient care. So it's not only saving the eye, so saving life is also part of patient care. So what we are going to discuss in the next 80 minutes is how to assess a patient plan for OP surgery and how to sense. So before that, how to sense and save a sinking patient. This is very, very important for preparation aspect. And try to answer all this WW about what we have to do, how we are going to do it, where we have to focus, and why we should do this, and when should we do this. And these are some of the key topics that are concerned with these medical emergencies. So one is having the right equipment and right training to the staff, and how to communicate the bad news to the patients and their attenders, and what are the common situations that we can encounter. So maybe we have a lot of time, so we can take questions from the audience. So I have a team of dynamic speakers and practitioners. Dr. Atik is ophthalmologist at Fatima Eye Clinic. So he will be talking to us about how to assess a patient plan for OP or daycare surgery. He is also the chairman ARC of Tamil Nadu Ophthalmic Association. And Dr. Gagan Dudeja is a principal assessor with NABH as well as consultant HOD of Orbit and Oculoplasty at Narayan Netralaya. He'll be talking to us about the standards related to emergencies from the NABH perspective. Dr. Kumaran Murugesan runs a Kumaran Eye Specialty Clinic, ophthalmologist with keen interest in practice and infection control. He'll be talking to us about how he managed medical emergencies in his hospital. And Dr. Jayanthan, currently the editor of TNOA and eye surgeon at KSI Hospital, will be talking to us about training required for emergencies and code blueprint. So this is the program. Please stay with us. I know lunch is, we are standing between you and the lunch. Right, so this is important. So I'll be talking to you about what all emergencies that can happen, how to sense and save a sinking patient. So has few case stories that really happened. A 35-year-old lady has come for incision and curettage, and ophthalmic diagnosis was easy, just chalazion, and suggested a OP procedure. It's a daycare procedure, chalazion incision and curettage, and xylocaine test dose, because we are not sure about the allergic response to the patients. So this is what happened. So the next few minutes, he started itching and suffocating sensation. So when we assessed, the patient was awake, oriented, but the voice was changing, and generalized flushing and breathing difficulties, and these were the vitals. So tachycardia, tachypnea, and the SpO2 was coming down. So how do we proceed? Can we make this as an interactive session? We can, some of you can answer, because these are common scenarios. Nothing related to ophthalm. This is just related to being a medical practitioner. Right, so these are the hints to the diagnosis: acute onset, secondary to a trigger, that is the xylocaine injection, and patient had this sense of impending doom. She was very anxious, and the voice was changing, and she was panicking. So this is anaphylaxis, and these are the things that happens in anaphylaxis. So the tongue gets swollen, inability to swallow, and the eyes get swollen, and these are the ways in which patient can react. So we all know anaphylaxis is acute, potentially fatal multi-organ disease, and it involves prior sensitization to an allergen followed by a re-exposure. So generally we do ask allergy to eye medication, but we rarely ask about allergy to previous medication or any history of surgery under local anesthesia. So this is not the appropriate time to waste in doing investigation, because this is a clinical diagnosis. Unless you are aware of it, you may not realize that this is the problem. So investigations are not helpful in this acute setting. All you have to do is recognize that, and within minutes start a treatment. So you have to, there are a lot of symptoms, so potentially more than 40 symptoms. It's not easy to recognize, particularly when you are in ophthalmic field for a long time. So there's a lot of debate about local anesthesia test dose, whether mandatory or not. For as per risk assessment, it may be needed for some patients. There is no standard guideline as such, but standards do prescribe local anesthesia test dose if there is a doubtful allergy to. But allergy happens to not only to the drug, which is dose dependent, but also to the preservatives. Most of our drug companies use a lot of preservatives, so they can be allergic to the preservative, and there is a cross reaction among local anesthesia agents, whether sensorcaine or bupivacaine or whatever it is. So you have to do a thorough risk assessment and initiate steps in the management of anaphylaxis. So focus on acute management. So protect the airway. This is very important. So you need to have a small plastic airway which cost about 40 rupees. So this is very important device for these patients. And adrenaline injection. This costs hardly less than 10 rupees. You need to have them at least 5 injections in any hospitals where we are doing surgery under local anesthesia. Of course, you can add the injection hydrocortisone and injection Avil. All are very common life-saving drugs. We have been used to this in house urgency. You also need to monitor the cardiac status, position the patient comfortably so that doesn't harm the patients. So preferably with legs slightly elevated, and initiate transfer, because this patient would need support for a long time. So you have to treat give the first aid and then transfer to the hospital. So you can extend. So this is another real story that happened. A 55-year-old lady was waiting for cataract assessment. Dilatation took long time. She became restless after 10 minutes and went to the reception and said, "I'm not well." As usual, our receptionist asked them to wait without realizing the situation. And after that, this was the reaction from the patient. She was holding the chest discomfort, profusely sweating, upper body discomfort, shortness of breath, and in few minutes was more or less the classical symptoms of cardiac event. So we carved code blue. So our team is prepared for it. We've been trained for code blue activation and what to do during a CPR resuscitation. So it was activated and patient became non-responsive. Artificial respiration was given, oxygen given, CPR given, and code blue done, and then patient was transferred to a nearby hospital in a cardiac ambulance and admitted in ICU. This is another story which happened in a busy Saturday OPD. Patient was waiting for in the OPD, well-controlled diabetes mellitus, and luckily patient was known to us. We know the cardiac condition as well as the diabetic conditions. Patient became agitated and started verbal abuse. Again, sweating and tremors. So what do we do? So this is what happened in few minutes time. So these were some of the symptoms observed. And so this is quite a common emergency. So all we need to do is do a capillary blood glucose and if needed ECG, but CBG is more than enough. Check the vitals, blood sugars, and recognize that it is hypoglycemia. So most of the emergency drugs will have oral dextrose or IV dextrose. So give immediately the patient recovered, and then the patient was sent for physician opinion. Since the patient is a dialysis patient, she is used to the hypoglycemic situation, and the attender were also very helpful. So this is a 89-year-old male posted for cataract surgery with grade 4 NS. So most of the VIP patients and high complicated patients come with so many comorbidities. So we gave all types of local anesthesia, intracameral, peribulbar, but patient didn't respond, agitated. So how do we go about? So we have anesthesiologist all the time as standby. So he was really helpful. So he gave IV midazolam to the patient, not to the surgeon. Patient settled immediately. How I wish I had that. But so we continued with monitored anesthesia care, waited for 15 minutes for the patient to settle down, and then proceeded with the surgery. Post-op was uneventful and discharge. So just to debrief you about all these stories, can happen anytime to any practice. It does happen to small as well as medium and large practices. It can happen even the OP or OT or in the external areas. So these are some of the common emergencies in daycare centers. Hypoglycemia, anaphylaxis, asthma can get exacerbated, particularly if the patient is sitting in a closed room with AC. Seizures can happen, and impaired consciousness and cardiac arrest. So there are many ways of being sick and defining critical illness. We need to prepare our center, mainly our staff, to handle those emergencies. So we need to have intelligent people in the reception, not intelligent reception. So who can check the vitals? Ideal to have a trained staff nurse who can check the vitals and also monitor the patients on a regular basis. This is very, very important because most of these patients spend a lot of time in the OPD for waiting for dilatation or some other investigation. So CCTV might help, and they also should be trained to handle the vital signs and note the abnormal vital signs. That is more important. Knowing normal as well as knowing abnormal is important, and we also need to know our patients. So most of us are regular patients to us. We need to know their age as well as the comorbidities, and should have a gut feeling when we see the patients. And risk assessment we need to learn, not only the having anesthetist there, but also the general profile of the risk assessment. Most of the anesthetists will flag a yellow sign or red sign when it goes beyond ASA 3 or 4 in eye centers, and definitely ASA 5 and 6 we need to take help of the general hospitals. So keep an eye on high risk patients. So elderly patients, multiple comorbidities, wheelchair, stretcher bound patients, and referred from other clinics because we don't know them, so they can give this. And you also need to assess your risk tolerance. So the risk to the surgeon is very, very important, and risk to the practice, and financial risk. So particularly when you're taking VIPs or advocates and press people, you have to be very careful about this. So you have to take the history, red flags, and do a thorough assessment. Not only ophthalmic assessment, but also a general assessment is important. So reassess and communicate to the team. So let's see how our patients are there now. So the first patient's doing well, admitted in ICU, recovered in 6 hours. And so this was the status. The second patient took lifestyle modification and came back for cataract surgery after 6 months, treated medically. And both these patients went on to give wonderful review. So not only the patients were happy, the team was also happy. So nothing can replace training, teamwork, the skills and knowledge, but it has to be applied properly during this emergency measures. So that's more important. So we can't go away from risk, but we have to take risk. So otherwise, so the important benefit is the ability to save lives. So thank you so much for your kind